You Are Not a Frog. Life hacks for doctors and busy professionals who want to beat burnout and work happier. I'm Dr. Rachel Morris. I'm a GP, TEN coach, speaker and specialist in teaching resilience, and I'm interested in how we can wake up and be excited about going to work no matter what. I've had 20 years experience of working in the NHS, both on the front line and teaching leadership and resilience. I know what it's like to feel overwhelmed, worried about making a mistake, and one crisis away from not coping. 2021 promises to be a particularly challenging year. Even before the coronavirus crisis, we were facing unprecedented levels of burnout. We have been compared to frogs in a pan of slowly boiling water, working harder and longer, and the heat has been turned up so slowly that we hardly notice the extra long days becoming the norm, and have got used to the low-grade feelings of stress and exhaustion. Let's face it, frogs generally only have two choices: stay in the pan and be boiled alive, or jump out of the pan and leave. But you are not a frog, and that's where this podcast comes in. You have many more options than you think you do. It is possible to be master of your own destiny and to craft your work and life so that you can thrive, even in the most difficult of circumstances. Through training as an executive and team coach, I discovered some hugely helpful resilience and productivity tools that transformed the way I approached my work. I've been teaching these principles over the last few years as the Shapes Toolkit programme, because if you're happier at work, you'll simply do a better job. In this podcast, I'll be inviting you inside the minds of friends, colleagues and experts, all who have an interesting take on this, so that together we can take back control to thrive, not just survive in our work and our lives, and love what we do again. So it's great to have with me on the podcast today, Dr. Amit Sharma. Hi, Amit.
Hi, Rachel.
Great to have you. Now, Amit's a GP partner. He's a GP trainer. He's also the managing partner at his practice. He's the chair of the West Berkshire PCN networks and also the clinical director of the Early Plus PCN. So that's quite a portfolio, Amit.
Quite a lot of different things. Yeah, absolutely. Keeps him busy.
Yeah, I was going to say, do you ever have time to sleep with all of that lot going on?
Yeah. Well, partly that's what we'll talk about. I guess it's about managing the time well, and I guess if we didn't, then they wouldn't be able to do half of those things.
Great. So I've got Amit on the podcast today, and we are going to be talking about naughty monkeys and how we give them back. Now, I don't know if people will remember, a while back I did a podcast with Dr. Caroline Walker, who's the Joyful Doctor, all about we've done one about COVID fatigue. We've done one about stress and anxiety. We've sort of done quite recently about moving on, about what happens next and what we do. And she was talking about this thing called the naughty monkey. And that's very much one of the areas that you're quite interested in. I know you've done a bit of work around that with trainees, and you do some teaching on it and stuff. So just first of all, what is the naughty monkey and why is that relevant for our listeners on the podcast?
The naughty monkey is an interesting concept. I think it's been described by Roger Neighbour, amongst others. But essentially, it's the things that the client or the patient in our case is actually bringing to the consultation. So it's, I guess, their agenda, but also their burdens that they're carrying. And the concern, I guess, is we want to help manage those naughty monkeys, those burdens. But essentially, we want to empower the patient and actually for them to take those burdens away for them with the advice and help and support that we can provide. But the danger, of course, is that those naughty monkeys stay in the room and never leave, and stay with the doctor or whichever health professional or any profession really that's working with people. And you end up keeping those naughty monkeys, and they create burdens and weigh you down.
Yeah. So I love this concept of the naughty monkey. It just sort of brings up such a great visual image of someone coming in and this sort of monkey jumping around your room and sort of destroying everything that is there. And it is true that people come in to see you with stuff. And I remember once a chap came in, and it was a student actually, and he'd had a dreadful childhood. And I felt so upset after I'd seen him, and after I think a friend had just committed suicide or something like that. Something dreadful had just happened to him, and he was incredibly upset. And I felt a wreck for the rest of the day, actually,
Mm.
afterwards. Is that the sort of thing we're talking about as a naughty monkey?
Yeah, absolutely. It could be exactly that type of scenario. It may be more subtle than that. That's fairly obvious, I guess. It may be more subtle. It may be actually the patient or the client actually needs help with housing, or they need help with finances, or they need help with their mental health, or whatever the issue is. But I guess the key is that they're leaving that firmly at your door, believing that you will address it for them, and I guess not taking it away or feeling empowered to deal with it themselves. I guess in psychology you would call it partly it's transference and countertransference. It's that sort of concept that we're looking at.
Mm. And so we've constantly got patients coming in or clients coming in with their naughty monkeys, and I guess it's fair to say it's not just GPs and it's not just doctors, but this can happen with anyone who deals with people who have problems that need solving. I'm thinking particularly of lawyers as well, who, you know, people come to them with massive issues and massive problems
Mm.
that they need them to solve. So this isn't specific for healthcare, is it?
No, I think any sort of high stress job where you're dealing with people, and particularly where there is, I guess, a professional relationship. What I'm interested in is actually the professional boundaries and how you maintain those in that relationship. So it's really anywhere where there is that professional relationship with a client or a patient, and where you're dealing with them directly yourself.
So I know the answer to this question is fairly obvious, but I'm going to ask you anyway, because I'm sure you'll have your own particular take on it. What happens if we really don't give the naughty monkeys back to people, if we just end up with a cage full of these naughty monkeys?
And unfortunately, I've seen this in colleagues, where actually the naughty monkeys are kept in the room, and they end up staying with the person. And what happens is that we become drained, we become burdened by these problems, and are unable to escape from them. And actually, we develop a cycle with our clients and with our patients where they feel that they can unburdened by coming to see the professional that they're seeing, and have some relief from that, have possibly some something to help them forget about the sort of the problems that they're having. But the professional themselves is actually then weighed down. And in the short term, you may not notice anything, but in the medium to longer term, it will start to have an effect, as you're unable then to give as much of your mental energy to other patients and clients who need your support just as much as those ones who are unburdening in that way. So we eventually can unfortunately see people actually burning out, and leaving the profession, or taking on different roles, because of that issue. So it's a really important one for us to tackle and to be mindful of, and it's something right from the beginning of my career I've been really aware of, the need to ensure I'm working within the right boundaries with patients.
And we're going to really like to explore that in a minute. But first of all, I'd just like to dig a bit deeper into what these naughty monkeys are and why it is so bad for us psychologically. Because we're healthcare professionals or lawyers, you know, we are people who, that's our job, is to help
Yeah.
people. Our job, to some extent, is to take that naughty monkey and tame it and
Yeah.
turn it into a good monkey.
Mm.
But what is it that really burdens us? Is it the emotions of it and the sadness, or is it the sense of responsibility, or is it something else?
Yeah, I think it's partly about ownership. So it is something to do with that responsibility. Of course, in the course of our in our jobs, we have got to help tame these monkeys. We've got to help support people. The example you gave, Rachel, is a really sad example. We wouldn't be human if we didn't feel sad or empathetic about that. But those problems are often not for us to own, and not for us to take away. And the resolution to those problems, yes, we can advise and help, but often, quite often, the patient or the client themselves has to be the one that takes the steps to actually curing that problem, or moving to a better place. There are numerous examples, which I'm sure we'll go on to, that we could give, where actually professionals can inappropriately take on responsibility for actual things that the actual client or patient should actually take on themselves, because that will empower them and will be better for them in the long run.
It's a really difficult one, isn't it? I think, do you think this thing about taking on responsibility is, yeah, we are responsible for a bit of it, aren't we? We're responsible for, trying to diagnose someone's healthcare needs and for
Yeah.
referring them and things like that. We're not responsible for if they choose to carry on smoking or what
Yeah.
life decisions they make. But we feel very guilty very quickly about stuff that probably isn't ours to feel guilty about. Have you seen that?
You just broke it up there. Sorry, Rachel. You just pixelated and broken up.
Okay, don't worry. Let's just wait a sec. Okay. Am I back yet?
Yes.
Okay, right. What I'm going to do is going to clap and then we'll take it from I'll ask that question again. Okay. So I've seen people feeling lots of guilt about patients. And is that because there's inappropriate responsibility being taken? Because I think healthcare professionals feel guilty about just normal stuff that happens about people's illnesses. If someone doesn't get better, they feel guilty. If someone's got a dreadful stuff going on in their personal life, we can feel a little bit guilty that we can't help, even if there's no help in the world that would actually do any. Is that reasonable? Have you seen that happening?
Yeah, definitely. And I've experienced that, myself. Where part of the reason we do the job that we do is because we feel a burden to help support people, and it really bothers me when I can't support someone in the way I'd hope, or they don't progress, or they don't get better, or they have a diagnosis that means they won't get better. That's really distressing, and again, that's part of the reason we do the job. But ultimately, I think we have to have an understanding of our role here. So I often tell my trainees this, but in our job, we're healthcare professionals. So we're experts in health, hopefully. We care and are compassionate, and that's really important to what we do. But we are professionals, and we always talk about professionalism in terms of being punctual, being on time, being appropriately dressed, and we think of that as professionalism. But actually, I think part of that is actually forming professional boundaries with patients and partnering with the patients. This concept that actually the patient is at the center of their health, not you as the clinician. You're a guide, you're a facilitator to enable them to better health. So your role there is actually to stay within that boundary and not to take on responsibilities that are actually the patients. So that's a key area, is to understand our role. And once over time we understand that and start to develop that, then it helps to manage some of the guilt and some of the raw emotions we can feel, which we all go through in our line of work and many other lines of work where you're dealing directly with the public.
I think there's two problems, aren't there? The firstly is that we ourselves are inappropriately taking on too much of the responsibility and too much of the the need to cure them or to make things better. We're in the rescuer role if you talk about the drama triangle, when you've got
Absolutely.
the rescue and the persecutor and the victim. And we sometimes see them as the victim who are completely helpless and can't do anything. There is the other side to that, though, is that they can be very quick to take on the victim role and give us their naughty monkey inappropriately. I mean, I know when doing consultation skills training, I remember the first time I decided to ask about ideas, concerns, and expectations. I said, what's brought you here, and what are you particularly concerned about, and what have you put this down to in your own mind? What would you like me to do about it? The first response I got was, well, I don't know. You're the doctor.
Yeah, absolutely. Yeah.
So, what do we do when actually people are throwing their monkeys at us? So take it. It's not mine. I don't want it. You have it. Because lots of people do that. People are quite bad sometimes about taking responsibility for themselves.
Yeah, absolutely. And that's one of the biggest challenges we have every day, really. And if you think about what drains you at the end of a busy day, it's actually those kind of consultations and encounters often, as well as the problem-solving aspect of making decisions and diagnosis. It's that exactly what you described, Rachel. I think in those situations, the first thing response I generally have is one of grace. And so I try and build a rapport with the patient. So if someone's saying, look, I don't know, this is your issue to sort out, try and unpack that first. Try and really understand, okay, why are you here? Kind of what has actually led to you coming in today. But then try and unpack some of the symptoms. If you're not getting anywhere, try and build some relationship, build some trust in the consultation, and then maybe you have to revisit that later on and sort of go back to it and say, well, actually, look, these are the things that we could do today. These are some of the things I could do, but these are some of the things you could do. And I guess when you're meeting someone for the first time, that can feel quite daunting to give someone responsibility and give someone ownership of their health, when you think, well, actually, they just come to get the advice that they want, and they want to be on their way. They just want the advice and get the help, and that's it. So that's part of the way you unpack it. I think obviously it gets easier as you get to know people, like anything in life. The more you develop the relationships with patients, the easier that conversation becomes. And we'll never do it perfectly. I mean, I certainly don't. And there's been many patients where I've been really aware that actually I'm taking this all on here, and actually I should be encouraging the patient to do that.
But there's another reason as well, I think, that we do take on too much, and I think that's fear.
Yeah.
And I think fear of complaints is a massive thing,
Mm.
and fear of mistakes is a massive thing, not
Yeah.
just in medicine but in law, accountancy, and many other
Yeah.
professions. So you go above and beyond and inappropriately take on people's things because we are so scared
Yeah.
of doing something wrong or someone putting in a complaint about us.
Yeah.
What do we do about that?
So that's definitely driving some of our behaviors, isn't it? And driving some of the things that we do and decisions that we make. In terms of complaints, the danger is that we just live and make all the decisions based on that fear. I think the reality is, most of the complaints that happen are because of communication, and rather than actual decision that was made. That's not always the case, but if you look at the majority of reasons, it's communication. So having good communication with the patient, and sometimes actually being honest with the patients about the dilemmas that you face, is really important, to share some of that risk. Ultimately, you're going to help them manage that, but actually sharing that and unburdening that, I've always found has been helpful, to try and manage that. But I think, Rachel, another question for me here though is it, there's a fear of complaints, but also there's a bit about wanting to be liked, and wanting to please, and certainly as healthcare professionals, but in other roles as well, we certainly can fall into that. And it's important we understand ourselves and understand what our values are really, and whether that is part of our personality. So that's something I always do, not just with myself and colleagues, but with trainees, is look at your psychometric testing, things like Myers-Briggs and Honey-Mumford. These can all be really helpful to understanding why we behave in a certain way with patients and clients.
I think that is so true. A lot of our behaviour is driven out of wanting to be liked, and actually that is driven out of fear a lot of the time,
Yeah.
because we know that our amygdalas react to certain things. They react to physical threats, they react to hierarchical threats, and they react to people not liking us
Mm.
threats. I remember a patient sat down. She came in once to the surgery, and before she'd said anything, she sat down in front of me. She said, "Well, I've just come to say that every doctor I've seen so far has been no effing use at all, so you'll be no effing use." And I
Yeah.
was just like, "Oh, that's
Yeah.
awful. She doesn't like me." I thought, hang on a sec. She's never met me. She has she has nothing to base this about apart from the fact I'm a doctor. But immediately I was triggered into, oh, she doesn't like me. And
Yeah.
we know why we get triggered, because, in our ancient, when we were living in caves, if we were if we were thrown out of the group, we would die of exposure. So it's like a proper threat thing. But again, so it goes down to fear of not being liked by people or not being accepted by the group. So we
Yeah.
do things to make people like us. And then you get the thing where you're overly taking on responsibility because you want them to like you.
Yeah.
And then you get into the drama triangle. And the drama triangle I find absolutely fascinating. It's one of the shapes we talk about a lot. And it brings, you can see when teams do it and doctors do it, they go, Oh yeah, because you've got the, for people that don't know about it, it was devised by Stephen Cartman in the 1960s. He was Eric Berne's student. Eric Berne is the father of transactional analysis that we've already talked about. But you've got the three roles, which you've got the rescuer, which I think GPs, accountants, lawyers, most professionals firmly sit in rescuer. Then you've got the victim, and that probably we see our patients or our clients as the victims that we need to help. Then you've got the persecutor, which is the problem, their health problem, or someone else that's being the problem. And the problem is we just move around. So we start off by wanting to be to the rescuer, to this poor victim. And then as soon as we as the rescuer can't give the victim what they want, i.e. sort out my back pain, make it completely better. If we can't do that, we then get put in the role of the persecutor. And that's where the complaints and stuff comes. So I think the only way we can really start getting out of it is just to step out of that role as rescuer completely, rather than taking on in the first place. So how can we do that?
Yeah, I think partly it's a conversation like this. It's actually understanding your role and understanding this is actually happening. And I think this is why, if from the outset you understand yourself and understand the psychology of the consultation to some degree, that's really helpful to know that this process is happening. And I think partly you have to work on this feeling of being liked, and it's and understanding that it's okay sometimes not to be liked. And actually, if every single consultation, every single client liked you and gave you 100% satisfaction, you're probably not challenging your patients. You're probably not doing something right, actually. And unfortunately, we do receive complaints, and sadly, it's become a norm that a doctor or any sort of professional really will expect some kind of complaint. I often say to the students now that if you never have a complaint in your career, or even over a 10-year period now, you're probably, or even any feedback, you're probably, again, not doing something right. You're probably not actually challenging your patients, because sometimes we do get, sometimes patients do respond to that. So I think having an understanding of the consultation, having an understanding that all these dynamics are at play, can really help us to unpack this and change the way we consult. Certainly, that's what helped me. I remember coming as a new GP, and the first year having some of these issues that we're describing, and I think that was a real learning curve for me as an independent GP. And I think about a year in, I realised that actually I probably was on that balance, or on that side of being the rescuer, and wanting to go over and above all the time.
Yeah, and you may get a complaint if you say no to someone, but if you can give your reasons for saying no, and then that's going to be fine. It's like you said, you can't please all of the people all the time. I'm thinking you're probably going to get a bigger complaint if you blur the boundaries, going above and beyond, and or overstep the mark in your
Yeah,
helping, and something goes wrong. Then
absolutely.
then that's when I've seen doctors
Yeah,
and other people get into real
yeah,
trouble when they've over helped and over rescued.
yeah. Yeah, and there's a cost to that, isn't there? And there's a cost to saying yes to everything. There's a cost to the patient themselves because they're not empowered, and fall back. They're not activated to manage their own health. There's a cost to the clinician, but it's also a cost to the colleagues as well, and other patients, because if you're devoting your weekly time and attention to this patient who should be doing more for themselves, it means you're not seeing other patients who could benefit from your help and support. And so but understanding these sorts of concepts has really helped me become more self-aware in the consult.
And how would you spot when you're in that rescuer role and being overly responsible and not and taking that naughty monkey on? What the telltale signs?
So one of the things is, I guess, how you feel about work day to day. How are you feeling after a day's work? Now, there can be many reasons why we might be dissatisfied, or feeling tired, or struggling at work. There can be many reasons for that, but this is one of the areas that you'll notice first. Really, is that you are struggling with your workload. You're struggling to manage day to day. You may also get comments from colleagues. Certainly, that's often been really helpful in my development, is colleagues are saying, well, actually, I saw this patient, and you'd offered to do this and this and this, and I'm not sure.
Are you mad?
I'm not sure you really should have done
Crazy man.
that.
Yeah.
So, and that's helpful. And you need an
Mm,
environment, a supportive environment where people are willing to give that kind of feedback and talk to you. And I'm really thankful where I work, that culture exists. So I think that's really important. But yeah, is that personal kind of dissatisfaction with work? It may be an initial sign that actually you are potentially taking on too much of the load. And then having peer review. I think talking to others and saying, well, actually, look, I'm doing this. I've got a feeling I might be taking on too much. I might not be. Let me give you an example of the type of thing I'm doing. Speaking to somebody who's perhaps of a different personality to yourself can often be helpful to kind
mm,
of
yeah.
find those gaps.
But the people that really struggle, that, and I know I've been a receptionist, so we were laughing earlier because actually the way I met Amit was because we were communicating on LinkedIn about something, and I spotted that you were actually from Brookside Group Practice, which is where I was literally brought up, quite literally. So from an old blast from the past. So I was actually a receptionist there in my holidays. My father was one of the GPs, and so actually, I remember working as a receptionist, and some doctors would just be over the whole time. You would know there'd be patients in them for hours sometimes, and other doctors would whiz through their patients. Now, there's a balance, isn't there? There's definitely a balance, but definitely the people that were really spent a long time and took all the problems on. And I guess in those days, probably that was more like what you did as a GP, as a real cradle to grave GP. But you can't do that now because there is too much work.
Yes.
You will get burnt out.
Yeah, the demands are much greater, and I guess the expectations of patients, quite rightly so to some extent, with all the different diagnostics and treatments we have now, are much greater as well. So yeah, you can't really function like that. So it is a big change, actually, I think, in the way GP is moving forward. But the other thing is, Rachel, we've got a number of other avenues of support and help now. So, for instance, with primary care networks, which are groups of GPs, we are sort of now employing people like social prescribers who are there to help with these kind of life issues, and they can spend 45 minutes or an hour with a patient properly going through all of these different issues that they have, and that is such a valuable resource, and one that we're trying to maximize the usage of. So actually, the GP isn't the only source of support. There is so much out there in the community, and volunteers. There's just so much support if we know how to access it and when the right time is to use it. And so, yeah, really reducing the reliance and dependency on us.
Yeah, I think we have a real hero complex, and when you're in the rescuer role, you have this hero complex. And I was really fascinated to find out. So I co-authored the Lead Manage Thrive course for Redwell, and we're doing the Working at Scale course, and we were talking about the public health determinants of healthcare. Actually, only 15% of somebody's health is determined by medicine. And the healthcare system, the rest is determined by their housing, by their genetics,
absolutely,
by society, by everything like that. So actually, if you think about healthcare, can only affect 15% of a patient's life anyway. And you, out of that 15%, is probably quite small as well, because there's all sorts of other things in there. So we really need to stop thinking we can do much about anything, really, or is that a bit nihilistic?
Yeah, no, we've got our role to play, haven't we? But that's it. We've got a role to play. We're not the owner of the patient's healthcare. They're the owner of their healthcare and all these other issues around them as well. And I guess that also makes me consider about the role of things like prescriptions. That's one of the most important things that we can do is prescribe things. That's as a hero, that's one of my main skills I have, is to be able to prescribe things. And it can be quite rewarding to prescribe, and the patients can often have that's their expectation to have a prescription. But sometimes that can be the worst thing to do, because if it's something where it's a mood problem, perhaps, which isn't severe and doesn't need it's not clinical depression, it doesn't need necessarily medication, and there are other avenues they could support. Giving them a prescription medicalizes it, and it continues to create that dependency. You know what it's like. You give a medication, it invariably get a side effect. So you get a phone call about the side effect. You then perhaps think about changing the dose or changing the medication, and you can go into that cycle. And there's lots of different drugs out there, so you could spend 2 years conceivably going through this cycle. And I know that because I think I did that once with a patient and thought, actually, I've just spent 2 years going through all of this, when actually the problems here are the issues at home. Let's talk about those. And that patient actually really unlocked a lot of this for me. I remember saying to her, could you just list all the things that you think could help you get out of the situation that you're in? She wrote them down for our next consultation, and we looked through it together. And I said, look, how many of these things do you think I could influence? And actually, it was just the prescriptions was the only thing that I was influencing, and probably, some of the drugs she might have needed, but some of some of it she probably didn't. And that was a great learning thing for me and for her. And she said, well, actually, I probably don't need to come back to see you. I said, we've also got these people called pharmacists. They can also help you with prescriptions. But actually, that was a great learning experience for me as to exactly that, the hero complex, and using prescriptions to fulfill that.
Yeah, and also using prescriptions just to solve the problem, to get people out the room
Yeah.
as well, because it is the easy thing to do. Let's face it. I think I've got a friend who's a very, very good family lawyer, but she does everything to try mediation and try get them to sort it out. It's like court is the last, the last ditch thing. You don't go in. Maybe we should be thinking more about, medical intervention and prescriptions being the last point of call rather than the first one, and actually empowering, getting the patient empowered to do their own behaviour changes is so important, isn't it?
Absolutely. And mental health's a big one, and I think that's a big part. But I mean, even with physical health, medications obviously have a massive role to play. But sometimes, if we look at the relative efficacy of using different drugs versus lifestyle change, if you think about cardiovascular health, heart health, for instance, there's no doubt that exercise, good lifestyle, all these things actually have a much, much bigger impact than any drug that's ever been invented. So we definitely need to push that agenda with our patients much more, and not be afraid to do that.
And at this point, I do just want to add the caveat to any of our listeners that
Yeah.
we're not saying don't take medication. It can be really helpful for
Yeah, of
all
course.
sorts of mental health and physical conditions. It absolutely do. But I think it's just getting into the mindset that our patients are able to do stuff for themselves, and our clients are able to do stuff for themselves. And for me, this was a huge mindset shift. So when I teach about the drama triangle on my Shapes Toolkit course, I always talk about, instead of a rescuer, we move into more of a coach mentality.
Yeah.
And we view the victim not as a victim, but as an activator, someone who is quite capable of solving their own problems, doing it for themselves. And of course, then you've got to also view the person who's a persecutor, or the thing that's a persecutor, not as a persecutor, an evil persecutor, but it's just a challenge or a catalyst. And for me, doing some coach training, learning how to coach, it really changed my life in terms of all sorts of things, because you immediately start spotting when you're rescuing rather than coaching, when you're trying to fix things rather than coaching. And actually health behaviour change coaching is really, really powerful. And I did just feel like this weight had lifted off my shoulders, because for the first time, I think I was really stupid, because I'd practiced medicine for 10, 15 years, thinking it was up to me to solve everyone's problems. And I suddenly realised that I couldn't. And it was up to them to solve most of their problems. It was quite a relief at the time.
Absolutely, and I've gone on a similar sort of journey myself with getting that understanding. And interestingly, I'm actually just doing coaching at the moment, going through the course at the moment. So that's been really helpful to kind of think through some of these things. And actually, our social prescribers and health wellbeing coaches, all of these roles are now exist, and they've often done exactly that type of training about health behaviors, and how we motivate people, that motivational interviewing techniques. And this is something actually, as a locally we've actually been doing in our patch to actually help train clinicians on motivational interviewing, even in 10 minutes, what you can do to try and move people forwards, rather than sort of dependent on you. So yeah, it's a massive deal. And one challenge I think that all clinicians, but so many other professionals have.
So, what advice would you give to someone, any professional who has a client or a patient who's well and truly dumped their naughty monkey on you? How do you hand it back? What are your top tips for giving that back and making sure it's not going to stay with you
Yeah.
after the consultation, or when you shut down your computer or you leave work?
Yeah. So as I say, first of all, I think you do need to, obviously in the consultation, you'll have unpacked some of it and understood why they've come in and understand what the actual issues are. I think I try and, as I say, partner with the patient and make it clear from the outset that you are a partnership. And for some, it may be easier in the legal setting and other settings, actually having you can almost have an agreement between you as to exactly how the relationship will develop. And certainly in coaching circles, that's much more familiar. But in the patient setting, that can be more difficult. But you do need to have that, I think, that discussion about actually here's the issues that we've got here, and let's share this plan of how we'll move forward. So one of the phrases I like to use is, these are the things that I could do to help today, and these are the things that you could do to take this forward. So it's really clear who's doing what. Sometimes writing it out can be helpful, but or nowadays it's all remote, so it's texting these things can be helpful. But actually having it down as a clear plan for you both really helps. I think that's often where there's issues, is where there's perhaps not a clarity at the end of the meeting. And it might mean that first meeting takes longer, takes much longer than 10 or 12 or 15 minutes, but that'll have a massive value in the long term, because you won't then be spending that 20 minutes the next time and the next time and the next time. And you've clearly set out those boundaries, not only for the issues that they've discussed today, but going forward as well. So making it clear what you are there for and what you're not there for, and signposting effectively to other sources of help that there are. To do that, you need to be aware of what's out there. So when you get those emails about different services, actually it's worthwhile knowing, what is out there, who can I refer to? And if you don't know now, go and find out who are my avenues of support, where could I delegate appropriately for my clients, because there is always support out there. We're just often not aware of it. So there's some of the top tips I would normally use.
Yeah, it's a great. I guess as you're saying that, I was thinking, my sort of top tips are very much as a coaching role. You would never come out of a coaching session with actions for the coach to do.
Yeah.
I might say, I'll send you a questionnaire or something that would be helpful, but I'd never say, right, my action is to talk to that person for you, or that, never in a million years. But often as a GP, you'd go, okay, well, I'll do that for you. I'll phone that person. I'll write that letter. I guess if you can get the patient to take ownership and responsibility for doing that themselves, that is much better.
Massive.
So I like self-referrals to physio. I like self-referrals to IAPS, all that sort of stuff, because it's the onus is on them and they're much more likely to benefit from it. They do it. So stop the doing it for everybody. And I think that applies to all professions.
Yeah.
And before you give advice, I think, ask them what they've already tried.
Yes.
Or what they think they could do about it. I think that's a really good, if you're a manager as well. That's my top tip for managers who don't want to burn out. When people come to you your teams come to you for advice, before you go, well, this is what you should do, go, oh, I've got some ideas. What do you think you could do? What have you already tried? What are your options? So ask them. I think you really need to watch out for pants on the outside syndrome, which is superhero syndrome, which doctors definitely have, lawyers definitely have it, lots of other professionals definitely have it, that we are superhuman and that our needs don't matter and that we're just there to give and give and give, because it doesn't end well. And then finally, I think something you said earlier was really important is peer support and debriefing with other people, because otherwise you get into your own sort of echo chamber of thinking that this is the right thing to do or it's normal. And it's so helpful when someone comes along and goes, that was an interesting way of handling that. And you think, is that not the way you do it? No. And then you sort of, and just debriefing, I've had this conversation. I'm not sure. I'm feeling like I've still got a bit of the monkey here.
Yeah. I've still got the baggage. Yeah, absolutely. And at the end of the day, when you debrief, those conversations are just so valuable, and have certainly helped me so much in my development and growth as a clinician. So you got to find people who you can talk to, debrief, and going back to the coaching, you'd have your coaching supervision, for instance, as an analogy. So you do need that input at times.
Yeah, and I'll get on my hobby horse here about how coaches have to have supervision, how psychologists have to have supervision. Doctors, you get an appraisal once a year. Do we have any mandatory formal supervision to talk about? You're seeing 30, 40 patients a day, all who have got these monkeys jumping around, and there's no regular mandated debrief supervision. I just think it's so important. So if you can find a peer to do it or a peer group to do it with or anyone, I think that's really, really important, even just informally with a friend having a coffee now and then.
Definitely. I think my wife's definitely a lot better at doing that. They've got a bit of a group of friends who have formed a bit of a balance group, and I think that's so valuable. We all need it. We all need to debrief, and sometimes it can be helpful to get some context from someone who's outside of your working environment as well, to normalize, because you can develop a bit of a culture of practicing a certain way. So getting a different perspective, someone with a different personality perhaps to you as well, really helps.
Yeah, 100%. Thank you so much. That has been so helpful. Really, really interesting. I think we're going to talk about that for a long time, but we do need to stop. Amit, if people wanted to get in contact with you, where could they find you?
Best places really, so LinkedIn, as you found me, so that's a really obvious place. I'm just Amit Sharma, no funny nicknames, and my sort of contact details are on there, so email is on there as well. It's probably the best way.
Great, thank you so much for speaking to us today, and hopefully we'll speak again soon.
Brilliant. Thanks, Rachel.
Thanks. Bye. Thanks for listening. If you've enjoyed this episode, then please share it with your friends and colleagues. Please subscribe to my You Are Not a Frog email list and subscribe to the podcast. And if you have enjoyed it, then please leave me a rating wherever you listen to your podcasts. So keep well, everyone. You're doing a great job. You got this.